All right. Our next speaker is my good friend, Dr. Robert Galler. Dr. Galler is the director of neurosurgery at the Peconic Bay Medical Center, and he's also the director of neurosurgical spine in the eastern region at Northwell Health, and also associate professor of neurosurgery at the Donald and Barbara Zucker School of Medicine at Hofstra slash Northwell. Dr. Galler has been involved with many trips to East Africa, including Tanzania and Kenya. I've been on trips with him. I've been on a trip with him to Kenya, and also we've collaborated in Tanzania as well. Dr. Galler, thank you so much for being one of our faculty, and welcome.
Thank you. I'm just going to share that screen again and we can get going. Um, Wanted to thank you guys for putting this all together. Obviously, we're constantly adapting to the world we live in, doing this conference virtually. Certainly not quite like the real thing, having traveled with you guys and spending a lot of time operating and teaching in person. But I'm really glad that we managed to keep this going. I look forward to the opportunity to travel again on the next trip and carry on the work that you guys have been doing, which I think is really extraordinary. So what I'd like to do is shift gears. Dr. Mangano is a dear friend of mine, and every time I hear him give a talk like that, it's just unbelievable to think that that technology and those techniques are even possible. I'm going to scale it back to something a little bit more uh, sort of in the realm of mortal neurosurgeons, and talk about degenerative cervical myelopathy. As I alluded to earlier, in reference to sort of global efforts, um, neurosurgery can be broken into, certain disciplines that get a lot of attention and some that don't. And I think spinal neurosurgery is one of those areas where, in the global arena, doesn't quite get the attention it deserves. We'll talk about this particular topic and then maybe have a discussion about how it impacts areas such as Kenya and Tanzania and other Eastern African regions. So, to start with the usual introductions, the management of cervical spondylosis is always a major concern to the spinal surgeon. What was considered cervical spondylotic myelopathy, an extremely common etiology for spinal cord dysfunction in adults globally. The neurosurgical literature continues to grow, but the spinal literature doesn't really give a full and clear consensus on terms of treatment. There are advocates for anterior approaches, there are advocates for posterior approaches, there are some advocates for no approach. Um, Studies have shown some promising results and good outcomes with both techniques, but each has some advantages and limitations that we'll go over. And the current techniques allow for excellent neurologic outcomes with both procedures, uh, and the disparity really comes in reference to the secondary part of the procedure, which postoperative fusion, either occurring or not, and the morbidity associated with that. So I'll start with a couple of clinical examples just to give an idea of this patient population. So this is a 50-year-old gentleman with progressive gait difficulty, excruciating left arm pain. He has clumsiness with grip. We examine him. He's got a positive Romberg sign. He's got a wide base gait. He's got increased deep tendon reflexes, brisk Hoffman signs, and clonus. He's got weakness and some patchy sensory loss. And so here in the States, we have access to MRIs as readily as you have access to a can of soda. So we get MRIs on everybody. But this guy really needed one. And what you can see here is rather severe cervical stenosis. And if my pointer can be visualized, C2, C3, C4, C5, C6, and C7. So C5, C6, and C6, C7, essentially what you see over here, these two axial cuts, there's essentially no spinal canal. CAT scan is an excellent supplement to MRI, and what you can see here is that there's a bony osteophytic overgrowth at these two levels. And here, what you can see is osteophytic change in the canal, and these specific osteophytes representing also that radiculopathy. He underwent anterior cervical decompression with fusion with an excellent result. Generally, these patients have a very nice postoperative course with minimal morbidity, about an hour and a half of surgery and 23 hours in the hospital, and then some physical therapy. Another example, this is another patient with rheumatoid arthritis, spastic quadriparesis. This patient was wheelchair bound, couldn't ambulate, had Hoffman's, and the various signs of myelopathy with more significant weakness. What we see here is a area of focal cervical stenosis. And what we notice on this patient is that you can see some spinal cord signal change, which represents the chronicity of this condition. This patient underwent an anterior cervical approach as well, and then recovered somewhat to the point of being able to ambulate independently. And one more case just to sort of show different approaches. This is a 75-year-old female with gait deterioration. She had a wide base gait, bad unsteadiness, couldn't ambulate, all of the signs and symptoms of myelopathy being displayed on exam. This imaging is somewhat different. And what we see here is this large, what we're going to show you is a calcified component causing extremely severe stenosis of the cervical spine. The CAT scan showing that this is OPLL, causing extremely severe spinal canal narrowing. This patient was approached posteriorly and underwent a cervical laminectomy with fusion, made a nice recovery as well. So getting back to the problem at hand, what we're referring to is cervical spondylosis, extremely common condition of the cervical spine. There are anterior approaches and posterior approaches, as I've shown you, and the optimal choice is somewhat a matter of debate. Part of today's talk is also trying to change the acronym. The current literature from some of the larger groups that study this really are now trying to adopt the term degenerative cervical myelopathy rather than cervical spondylotic myelopathy to imply a bit more specificity regarding the pathology. So if we take this new nomenclature, degenerative cervical myelopathy sort of is the umbrella covering cervical spondylotic myelopathy, which is what's often referred to as disc disease with osteophytes and deformity of the vertebral body with hypermobility. And then there are the very specific pathologies such as OPLL, ossification of the ligamentum flavum, behavioral factors, cognitive factors, other things, and sports-related factors that go into the pathology and the pathophysiology. This slide shows basically every possible pathology one can have simultaneously, and it's a good example of the various conditions one sees. We have a bit of ossification of the posterior ligament. We have a little bit of ossification of the ligamentum flavum here. We have an area where the spinal cord has been compressed to the degree where it has got cavitation, and down here we have an area where there's proposed signal change. We have potentially hypermobility, listhesis, and many of the other subtle signs and symptoms, subtle findings that can cause signs and symptoms of myelopathy. So the epidemiology and overview of degenerative cervical myelopathy. Well, it's due to degeneration of the spine. It's one of these things that can't be fully unified because the pathologies are extremely variable. There's inconsistent terminology, and the novel term DCM is expected to elucidate the epidemiology of myelopathy caused by degenerative changes of the spine. The pathophysiology that we're discussing can be broken down into either a static insult or a dynamic insult. The static insult implies degenerative discs, osteophytes, and large ligaments, facet joints. The dynamic insult could be instability or increased range of motion. This can result in a disruption of the microvasculature. The pathology then implies endothelial damage, inflammatory reactions, apoptosis of neurons in the oligodendrocyte glial cells, and neuronal loss, finally demyelination. The clinical presentation and the progression can occur during the spectrum, and the degree of such is often very variable. Incidence and prevalence in North America, 41 per 1 million prevalence, 605 per 1 million. And just to differentiate these terms, the prevalence refers to the proportion of persons who have a condition at or during a particular time period, whereas the incidence refers to that proportional rate of persons who develop the condition during a time period. The natural history is mixed and generally has been studied over the years with varying result. Um, Overall, it's a stepwise neurologic decline with various periods of quiescence. The contemporary literature indicates 20 to 62% of patients will deteriorate at 3 to 6 years of follow-up. And this was by the modified Japanese Orthopedic Association scale. But not many of us test our patients with chopsticks, so we have to consider other methods for clinical evaluation. Non-operative treatments employed include cervical traction, collar, analgesics, physical therapy. Multiple studies have explored the prognostic value of several demographic and clinical radiological characteristics. But unfortunately, nothing has been really shown to reliably predict the risk of neurologic deterioration associated with these conservative strategies. And this is something that some of my colleagues in the States will commonly encounter in seeing patients in second opinion, where one neurosurgeon would say, if you don't have this taken care of, you can become quadriplegic with a simple fall or if you turn your head funny, which of course we know isn't true, but it would be nice to have a reliable way to tell a patient based on imaging exactly what their prognosis would be. And so this requires more study. The natural history has been studied pretty extensively, and back to the time of the development of the ACD, 1956, in that region, 75% of the patients deteriorated in stepwise fashion, 20% was slow and steady. Looking at the more contemporary studies, what we see is that patients do deteriorate, but treatments are initiated. The Neuric scale is one of the more standard methods that we use to grade myelopathy, but the studies that were performed during that era included laminectomy without fusion and techniques that were somewhat less than as elegant as we use now, leading to the belief at the time that surgery almost uniformly was associated with poor result. Just to shift gears a little bit to talk about why to take care of this condition and maybe why surgery is a good idea. Studying the economics of what we do, what we find is that surgery can have an extremely positive impact on the quality of life, and that quality of life transitions into an economic benefit. The question is which patients will benefit the most, which procedures are cost effective. This was studied actually by Dr. Hartle's group in Tanzania regarding cranial patients and some spinal patients, and they found that there was benefit in terms of quality of life and economic result in terms of return to work, return to activities. But as you can see here, the annual hospital charges for surgery of this sort in the United States can be upwards of $2 billion a year. So it is an industry. Some specific pathologies that we're going to discuss: ossification of the posterior longitudinal ligament, very specific pathology shown in that third case. These conditions can coexist with ossification of the ligamentum flavum, or even the anterior ligament, or diffuse uh, uh, dish type syndromes, diffuse idiopathic skeletal hyperostoses. Um, the summary of surgical approaches to OPLL and their advantages have been looked at. There have been studies showing multi-level corpectomies and circumferential decompression with fusion. These are associated with significant morbidity and complication rates. Posterior approaches do have some advantage of avoiding that anterior CSF leak and dysphagia. However, C5 palsy is associated with that in a proportion of cases. Um, Ossification of the ligamentum flavum, the posterior most ligament can also become significantly calcified, causing compression, somewhat more rare, but often seen, difficult to image. Imaging diagnosis is done through sometimes standard radiographs, CAT scan, and MRI, as I've shown, and the different characteristics are notable, and each has its own use. Um, Next level will probably be microstructural imaging, such as DTI or diffusion tensor imaging, or ways to see the tracks, ways to see levels of atrophy, and maybe functional imaging. Strengths and limitations of current imaging techniques. And This is sort of a pretty self-explanatory slide. Here's some nice comparative imaging showing standard radiographic technique in the upper left, showing some microinstability, spondylosis. Here on MRI, of course, you can see that there is stenosis, a herniated disc, and some spinal cord signal change. Switching to CAT scan, we can see diffuse facet arthrosis, and then an axial MRI image showing the diffuse anterior compression and also some ligamentum flavum hypertrophy causing diffuse circumferential stenosis. This is exhibited a little bit more in these images as well, showing the various appearances on MRI and CAT scan, which each has its benefits. Not always can they both be obtained, but when possible, absolutely can be useful in surgical planning, knowing that there's calcification or knowing that there is ligamentum hypertrophy associated with the pathology. So options for management with patients, and we'll start with mild degenerative cervical myelopathy. Um, the most commonly seen patient is that in the office with a brief bout of neck or arm pain, numbness, and tingling. Their referring doctor sends the patient to you. The imaging shows maybe rather severe looking pathology on imaging, but the clinical scenario is somewhat mild. In these patients, they can be managed conservatively. There is a role for surgical treatment, but it is controversial. And I think that unfortunately there's variability because the literature doesn't suggest a concrete paradigm for the management. Um, Again, we have patients that come in with cord compression but no evidence of myelopathy. We have to understand the importance of the decision making in these patients, and careful imaging is going to be important. And in the future, we'll probably have the ability to image them in functional ways that maybe can prognosticate a little bit more accurately. Um, some literature review of the conservative management. And what you can see is that it is variable. You have a certain number of patients who simply improve. Depending on the series, you have uh, within a year of each other, these two studies, 69 improved, and over here, 62 deteriorated. Here, 80 improved. So it's one of those things where the variability does provide some difficulty. Again, these are retrospective studies. Prospective studies generally not sort of class one type data. So changing path switching to the idea of surgical treatment. Anterior surgery for the treatment of cervical myelopathy, very common approach. Most neurosurgeons and orthopedic spine surgeons are very comfortable with this approach. Can be done from multiple levels, 1, 2, 3, and even 4 at times. The more levels you do, though, the more complications ensue. Dysphagia being a subtle one that is underappreciated, I think more common than we recognize. Anterior surgery is well tolerated. Hospitalization and cost of caring for the patients in the hospital setting is a bit less overall than the posterior approach, but has its own associated issue. Just to review that anteriorly, some nice diagrams that we always like to look at just to change the tone. Going anteriorly is nice because of the fact that other than cutting the platysma muscle, the surgical planes that we take are rather natural and is a non-destructive method of getting to the spine as opposed to posterior approaches. And that's notwithstanding some minimally invasive techniques that are maybe muscle sparing or the like, but this is a nice anatomical corridor that lends itself to the approach to the spine. One or more discs can be removed and using micro instruments and ultra flat foot keratins. Osteophytes can be safely removed, decompressing the spinal cord. These are some cadaveric specimens from back in my fellowship when I was studying the biomechanics of various constructs. Corpectomy here on the right and multiple discectomies here on the left with plate instrumentation. Bone graft or now cages can be utilized to supplement that space, or multiple cadaveric bone or cages made of varying materials now currently PEEK or titanium or combinations thereof are often now utilized. Varying machining techniques for corpectomy without instrumentation, which really isn't done often anymore, if at all. And here's a titanium cage packed with bone with a plate on the surface as an example. The decompression anteriorly should be taken out to the foramina bilaterally. And here's a little surgical video, if I can get it to go, that shows the technique under the microscope, clearing out ligament and drilling out osteophytic bone. And the osteophyte can be removed using the drill under the scope. And eventually you get to the point where you get to use your keratin to remove soft tissue. What you start seeing now is that there's a difference between the posterior annulus and the posterior ligament. Now the keratin can be used to remove osteophyte. More of that can be removed. And now you can see the dura. Dura completely exposed, all of the ligament and all of the other material, causing compression now completely gone. And now plate fixation with inner body grafts in position. Posterior approach, laminectomy with or without fusion. Standard laminectomy techniques have been around for quite a while. The addition of instrumentation and fusion, more of a contemporary technique. Obviously, the successful treatment requires adequate decompression primarily. And how I refer to this is that the primary operation is the decompression of the neural elements, and the exit strategy is the fixation and the restoration of balance. Fixed cervical kyphosis is generally a contraindication for a posterior only approach. And laminectomy alone is associated with post-laminectomy kyphosis and axial back pain, which has to be considered. Posterior approaches, the use of tongs or clamp or varying head holder techniques for positioning of the skull. Posterior approaches through the posterior cervical musculature, which is a bit more painful for our patients. The idea would be to create a decompressive trough, elevating the lamina, either in a laminoplasty technique, which has been advocated by some, or a laminectomy technique, which complete removal is performed. And secondarily, then the supplementation of instrumentation in the form of lateral mass screws for stabilization. And there's a video. This is a video of. Oh, no, it's not a video. It doesn't work. This is a laminectomy with lateral mass fusion. What you can see are the retractors in position, pushing the musculature out of the way. A bit more invasive than the anterior approach in that regard. What's become more important to consider in the patients with degenerative cervical myelopathy is not only decompression fusion, but maintaining balance. What we know from our deformity patients is that sagittal and coronal balance has become an extremely important indicator in terms of their outcome, and getting proper balance will help our patients in terms of long-term outcome in terms of neck pain. And the question is whether or not this has an effect on adjacent segment degeneration isn't clear. This is a patient I had seen in consultation who went to see another physician for treatment. This was the pathology at the time I saw them. They had a significant radiculopathy and early myelopathy. They went ahead and saw somebody else who did a cervical laminectomy without fusion. And what you see is an early development of kyphosis in the region of the laminectomy. So I saw the patient back in the office and offered them revision. And so what we see here on X-ray is that they're even developing an osteophyte as the kyphosis was maturing, and the myelopathy, and the patient was also developing significant C5 and C6 palsies. So we took them to the operating room, reduced them. I did a multi-level cervical discectomy with fusion, restoring their balance, leading to a very nice outcome. So this is a subtle aspect of spine surgery that doesn't get enough attention, I think. And I think it's one of those things where the younger generation of neurosurgeons knows much more about it than I do. And I think it's much to their benefit. Restoring sagittal balance, as you can see from several studies, does allow for maintenance of anatomical integrity and is associated with improved outcomes overall. So in summary, for future directions, I think advances in imaging, MRI technology, tractography will allow us to image and prognosticate more accurately. There are now machine learning models and some predictive models that are very interesting. I think that will have an impact on our ability to make decisions. I didn't really get into neuromonitoring, but spinal blood flow measurements and other methods of intraoperative monitoring to maintain safety, I think will allow us to improve our outcomes. There are biological advances that are being developed. I didn't really get into some of the details of such, but riluzole corticosteroid use is often employed for patients with radiculopathy, corticosteroids that is. Riluzole is being studied as a treatment for chronic myelopathy and is also being studied for spinal cord injury. Other mechanisms for repair, such as actual disc regeneration, are being studied, as well as neural stabilizers and other treatments for chronic myelopathy, spinal cord signal change. Then the question is whether or not motion sparing or motion preserving technology is appropriate for these patients. This is still being looked at. Navigation, robotics for safe and accurate instrumentation is now becoming more popular. in terms of cervical spine, not quite as popular as in the thoracolumbar spine, but it's definitely getting a momentum here. And the most important thing is getting level one clinical evidence so that our decision making is not based on this is how I do it, or this is a series of patients that I looked at, something much more concrete that will allow us to be um, very, very specific in terms of treatment paradigms. Um, so that's it with this particular topic. And what I wanted to end off on is just to comment more on the work that's being done by Dr. Awar in the group. Um, this is a paper I've been working on for a bit, and as I alluded to earlier, we have all this data, and I want to employ all of the folks on this call to maybe get involved and stay involved. I think Bethwell is there now. I want to sort of request that he uh, continues to gather the data, because these types of trips and these types of things that we're doing are only going to be able to be determined helpful if we can prove that we are helping. And the only way to do that is to get the data. As you can see here, from 2018 to 2019, when the trips were very active before COVID hit, you can see about 160 surgeries were done, varying craniotomy, spinal surgery, shunts, and spina bifida cases. You can see here. I think the outcomes have been excellent. I think that the ability to improve outcomes uh, is always there, and I think that the teams that are going are just phenomenal in the amount of work that they're doing. Again, this is that slide on the spinal surgeries that have been done there, which is my little corner of the world. And I want to emphasize that these cases should be done, and they should be done either by neurosurgeons or in concert with orthopedic spine surgeons. And I think that they have a huge impact on the population locally there. And so this is a picture of the sunset from one of the little spots that we would go and have a drink after a hard day of work. I look forward to seeing it again. And with that, I'll conclude.
Thank you so much, Dr. Galler. I remember that sunset and miss it as well. So hopefully in February of 2023, we can all do our next trip and go back to Kenya. We only have time for one question, so I'm going to turn it over to Dr. Karras. We're going to have one question, and then we're going to move on to our panel discussion, which will be overcoming barriers to neurosurgical training in Africa, kind of continuing on from where we left off with our first panel discussion. Dr. Karras.
Very good. So we did have a question from one of the participants about the use of intraoperative neurologic monitoring prior to you discussing that a little bit as one of the advances. And so I do want to ask either Dr. Olunya or Dr. Ogutha, is there any limitation to these types of surgeries that Dr. Galler discussed with regards to instrumentation? So in your setting, is instrumentation cost prohibitive? Is it not available? Or is it as accessible as it would be for any case that you need it for? I'd like to hear your perspective on that.
Thank you very much. I'm now on Feratarma. I'm not moving anymore. This is Nairobi. Just if I may, the instrumentation that were used, that Dr. Gala showed, is some that we have access to here locally. The costs themselves are one of the things that pushes it out of the reach of the majority of people. However, the trade has changed. We have some implants coming in from the East, some from China, some from India, some from part of Asia, which are more cost effective. So in effect, in terms of putting the implants in, those implements are available. When COVID hit, some of our major suppliers who were from Europe were really hit because they had issues of getting stuff across to us, and the competitors came in through, like I say, from Korea and so on. So they are available. Number two, just to add on to that, in terms of monitoring, we do have the trade. People come in, actually monitor for us perioperatively. We don't actually have to buy the equipment. So they run and follow you wherever the surgeries are done. But yes, the cost implications of the implants are usually above what most people can afford. Over to you, Lee.
Can we have Lee's microphone on, please? Thank you.
Hello, can you hear me?
Yes.
Yes, thank you, Dr. Lunya, for the comments, and thank you, Dr. Gala, for sharing a beautiful picture of Kisumu. I agree entirely with what Dr. Lunya mentioned, that we do have access to the implants. Where I am in Kisumu, I don't have a supplier in town, but in Eldoret, which is a town about 3 hours away from Kisumu, there are suppliers who provide us with implants on a regular basis. Right now, it's possible for some of the surgeries to be covered by our national health insurance program that brings the costs closer to what patients can afford. Sometimes they have to have a bit of a top-up or a co-pay, but usually when they have that cover, we can make it affordable for them to receive help, surgical help for these conditions.
Very good. Thank you very much.
All right, thank you so much. Thanks, Dr. Gutha and Dr. Lunya, who are joining us from Kenya. We really appreciate your input.